Thank you for joining today's Cost Measure Field Testing webinar. The purpose of this webinar is to provide information about the field testing of 5 episode-based cost measures before their consideration for potential use in the cost performance category of the merit-based incentive payment system of the Quality Payment Program. I will now turn it over to Dr. Ronique Evans from CMS to start the presentation.
Thank you. My name is Ronique Evans, and I'm the MIPS Cost Measures Lead from the Center for Clinical Standards and Quality at CMS. And I will go through the next few slides for our introduction before handing it over to our measure development contractor. This CMS disclaimer notes that this presentation is a general summary intended as a reference document for stakeholders. Next slide, please. Today, we will provide an overview of the cost measure development process, the 5 episode-based cost measures being field tested, the materials and activities that are part of this year's field testing, and the information included in the field test report. Next slide. Here are a few acronyms we use throughout the presentation that may be helpful for your reference. Next slide. To begin, I will provide background for the MIPS cost measures. Next slide. The Quality Payment Program has 2 tracks for clinicians to choose from: Advanced Alternative Payment Models and the Merit-Based Incentive Payment System, or MIPS. Clinicians who participate in MIPS have their performance assessed across 4 categories: quality, cost, interoperability, and improvement activities. A clinician's performance score for each category is rolled up to a MIPS final score, which then determines a payment adjustment. CMS has developed a new participation framework called MIPS Value Pathways, or MVPs, as a way to connect the quality, cost, and improvement activity categories while maintaining the promoting interoperability category and population health measures in the foundational layer across all MVPs. The goal of the MVPs is to simplify participation in MIPS and to provide clinicians with a set of aligned measures across performance categories that are meaningful to their care practice. 7 MVPs will be available starting in 2023. Each of these MVPs include at least 1 cost measure. Each of the MIPS performance category has a weight assigned to it. The weight of the MIPS cost performance category has increased incrementally over time. 2017 was the first year of MIPS, and the cost performance category was weighted at 0%. Each year since then, it has increased by 5 or 10% to provide clinicians with adequate time to prepare and gain experience with the cost measures while they represent a smaller portion of the MIPS final score. The cost performance category increased to 10% in 2018 and 15% in 2019. In 2020, the cost performance category was set to remain at a weight of 15%, but was reweighted to 0% and redistributed to the other performance categories due to the impact of the COVID-19 pandemic. The weight of the cost performance category continued at 20% in 2021. In 2022, the cost performance category will now make up 30% of the MIPS final score, which is required by statute. This means that the cost and quality performance categories are now equally weighted at 30% each. Within the cost performance category, the score is calculated as an average for all cost measures that apply to a given clinician or clinician group. Cost measures represent the cost of care for the items and services furnished to a patient during the episode. Currently, there are 2 general types of measures in the cost category. The first are global or population-based measures, which focus on broad types of care. Specifically, they focus on clinicians who provide primary care type services and who provide care in an inpatient hospital setting. The second type of measures are episode-based cost measures, which focus on clinicians who perform specific procedures and provide care to treat or manage particular conditions or other defined types of care. All of these cost measures are calculated using administrative claims data, so there is no additional reporting required for clinicians. The MIPS cost performance category started with only 2 cost measures in the first year of MIPS. Since then, we have gradually added measures, including 23 episode-based cost measures, and completing comprehensive reevaluation for the two population-based measures. There are now a total of 25 cost measures in 2022. The 5 measures with an asterisk are new for 2022. Next slide, please. There are currently 7 more episode-based cost measures in development. The measure development contractor uses a process based on cycles or waves of developing a number of measures at the same time. The current wave of development is the 4th set of episode-based measures and covers a range of clinical areas, settings, and conditions. The first 4 measures listed here are being developed in wave 4 and are currently undergoing field testing. The emergency medicine measure focuses on the care provided by clinicians in the emergency department. The intent is to comprehensively assess ED care, so it includes visits leading to both discharge and hospital admission, while also accounting for the many different reasons that patients attend the ED through risk adjustment. Next, there are 3 measures that assess the outpatient treatment and management of conditions that affect a large number of patients, often over a long period of time: low back pain, heart failure, and major depressive disorder. The 5th measure is one that had initially been developed in 2018 and has been undergone refinement since then. It is now being field tested with some minor updates that still preserves the intent of the measure to focus on the inpatient treatment and care for psychoses and related conditions. The last 2 measures in this table are chronic kidney disease, or CKD, and end-stage renal disease, or ESRD. These were initially developed for use in the Kidney Care First option and the Kidney Care Choices model, and are now in the process of being respecified for use in MIPS. These 2 measures will be field tested in the future, so they are not part of the current field testing. Next slide, please. Field testing is one of the steps in the cost measure development process, so this is the 4th time that we are conducting a field testing period. Field testing will take place over 7 weeks from January 10th to February 25th, 2022. During this time, stakeholders will be able to review detailed information about the measures under development and share feedback on the specifications. Clinicians and clinician groups will be able to assess field test reports on the Quality Payment Program website, which describe the performance on the measures as currently specified, if they have at least 20 episodes. All stakeholders will be able to review draft measure specifications and testing results on the MACRA feedback page. Everyone can submit feedback via an online survey about any aspect of the draft measures. This feedback will be considered in the next steps of wrapping up measure development. I will now turn the presentation over to Joyce Lamb from Acumen, the measure development contractor.
Thanks, Renee. Next slide, please. My name is Joyce Lamb, and I'm the project manager from Acumen for the Cost Measure Development Project. I'll start by providing a brief overview of the cost measure development process before diving into the details of the measures and the field test reports. Next slide, please. Our measure development process involves gathering extensive stakeholder input to ensure that the measures are clinically valid and can meaningfully assess a clinician's cost of care. As Renee mentioned, we've been developing episode-based cost measures in cycles or waves where development activities take place on the same timeline. We convene expert panels called clinical subcommittees and clinician expert work groups, or work groups for short, based around clinical areas or topics. These panels provide input on measure prioritization and specification. We're now in wave 4 of development, which began at the end of 2020 and is involving the input and expertise from over 73 members across 4 work groups. Across the 4 waves, we've worked with hundreds of members affiliated with many specialty societies, professional organizations, and other associations. Next slide, please. This slide goes through the stakeholder engagement process in Wave 4. We've been convening multiple panels, each of which serve a distinct role. We have a standing TEP, or technical expert panel, including members from a range of clinical, academic, practice, and patient and caregiver perspectives. The TEP provides high-level guidance for topics across the project, such as the measurement framework and other considerations that apply to many measures. This includes input on how to prioritize measures for development, what specific areas to focus on given the current coverage, and considerations in designing service assignment rules. Next, we sought input on which measures to develop in Wave 4 with a 7-week public comment period. This was a modified approach to provide more flexibility in measure prioritization from earlier waves when we had convened clinical subcommittees, which are large panels of clinician experts around a clinical area such as cardiovascular disease management. During the public comment period, 36 stakeholder organizations and individuals provided feedback on candidate measure concepts, approaches to address clinical and coding challenges, and the expertise necessary for a small panel that would build out the measure. With this feedback combined with empirical analyses and environmental scans, we worked with CMS, who then confirmed the final 4 measures that we're developing in Wave 4. Once the measures were confirmed, we posted a call for nominations in April and May 2021 to convene our 4 work groups. Each work group is composed of 15 to 20 members with experience and expertise in the area of care being measured. Work groups provide detailed input on every aspect of the specifications across multiple meetings. In tandem, we sought input from person and family partners, or PFPs, that is, individuals with lived experience relevant to each measure. PFPs shared their feedback through focus groups and interviews, with 1 or 2 PFPs also joining work group meetings to discuss the PFP's findings on aspects of the measures, like their care team and ways that they believe that their care experience could have been improved. Next slide, please. Here, this slide shows the timeline of each stage of development activities for the Wave 4 measures. The whole process spans about 18 months, starting with a public comment period for measure prioritization in December 2020. Since then, the work groups have met twice in June and August of 2021 to discuss the measure scope, service assignment, exclusions, and risk adjustment. After field testing, we'll share all the feedback about the draft measure specifications with the work groups to help finalize the measures. Next slide, please. So that covers the process for the 4 measures being developed as part of Wave 4. There is a 5th measure that is also going through field testing at the same time, which is the Psychoses and Related Conditions measure. It was initially developed and field tested in 2018 as part of Wave 2 under a similar development process. The measure was considered for use in MIPS, but was not implemented at the same time as the 10 other measures developed in Wave 2, as there were some concerns about the focus on the role of inpatient clinicians in treating these conditions. As such, CMS had included a request for information in the 2020 Physician Fee Schedule proposed rule to gather further input on the measure. Since then, stakeholders have also shared additional feedback. Using all this information, we reconvened the Psychoses and Related Conditions Workgroup in October 2021 to consider a specific set of revisions to the measure. With this timing, it happened to align with the Wave 4 measures, which allowed it to go through field testing at the same time. Next slide, please. Across all 5 measures being field tested and all our development activities, we're guided by principles that have been defined and vetted by the TEP and other stakeholders over the past years. These principles are intended to hone in on the specific aspects of a measure to allow it to be effective in assessing clinician cost performance. This slide includes the list of criteria that we keep in mind when developing measures. Clinicians should be able to review and readily understand measure specifications and be able to anticipate when an episode will be attributed to them. Since the measures capture costs related to various aspects of clinical care, whether episode-based or population-based, it's important that the measure specifications have clinical face validity and be consistent with practice standards. The measures should include costs of care that relate to the clinician's role for the particular measure focus. This is important so that the measure can be used to convey information that clinicians can then use to influence costs and improve their performance on the measure. Sometimes the set of services in the measure could be broad to reflect a broader clinician role, for example, a measure that focuses on primary care, while other times it could be more specific to a defined procedure, like a cataract removal. One related consideration is that the measure should include services such that the measure has sufficient variation in being able to distinguish between good and poor performance. Lastly, on a practical note, measure specifications must allow for consistent calculation and reproducibility using Medicare data. By having a general framework for cost measurement, it helps ensure that the measures follow these principles while also being flexible enough to create measures for the care of each condition, procedure, and setting being assessed. Next slide, please. I'll now walk through the construction of the heart failure, major depressive disorder, and low back pain measures. Next slide, please. These 3 measures share a similar construction methodology, as all are focused on capturing the role of clinicians providing outpatient management of the specific condition. This slide lists out the steps of measure construction. For reference, these steps are also illustrated in more detail on the following slides. First, we identify the patient cohort by looking for a combination of services and diagnoses that indicate the start of a clinician-patient relationship focused on a particular type of care. Identifying these meta codes is just one of the pieces of measure construction that our work groups help us to identify. Second, since chronic conditions are by their nature ongoing, we identify the total length of this clinician-patient relationship by looking for additional services that indicate a continuing relationship. Third, we define an episode as a set period of time during which costs will be assessed and then attributed in the study period in which it ends. This episode forms a unit that allows us to examine costs and compare clinician performance. For greater granularity, episodes can be stratified into a set of mutually exclusive, exhaustive patient cohorts called subgroups. This stratification allows the measure to focus on more homogeneous clinical groups within the overall patient cohort. This technique is something that we can use in all the measures for more meaningful comparisons. For instance, the diabetes measure, which is new for MIPS in 2022, uses subgroups for type 1 and type 2 diabetes. Fourth, the episode is attributed to the TIN or clinician group that provided the initial set of services that indicate the start of the clinician-patient relationship. Fifth, we assign services and costs to the episode. The set of services reflect the role of the attributed clinician for that particular measure and encompasses clinically related services where the clinician can reasonably influence the occurrence, intensity, and frequency of costs. The heart failure, low back pain, and major depressive disorder measures all include certain Part D services in addition to Parts A and B services. This is something that's considered on a case-by-case basis, and for these three measures, Part D drugs were considered to be integral to the care for the conditions and an important part of assessing clinician cost performance. We use standardized costs, which remove variation in payment that is not due to clinician care choices, such as geographic differences in labor and adjustments made under Medicare programs, like for graduate medical education. We calculate the standardized observed cost as a scaled figure, since episodes can be different lengths depending whether, and if so, when we see evidence of a continuing care relationship. Sixth, we apply exclusions to remove certain episodes from measure calculation. These exclusions ensure that we have complete data for each episode and remove episodes that are so different that they can't be adequately accounted for through other techniques. Seventh, we calculate the expected cost for episodes by applying a risk adjustment model separately for each subgroup and Part D enrollment. This model adjusts for factors outside the clinician's control that can affect the costs of care, such as a patient's pre-existing conditions. Risk adjustment ensures that providers are not penalized for treating more complex patients. Finally, the measure score is calculated as the weighted average of the standardized observed over expected episode cost ratios across all attributed episodes, where the weighting factor is the number of assigned days during the episode. We do this weighting to account for longer episodes. We then multiply this weighted average episode cost ratio by the national average observed episode cost to generate a dollar figure. Next slide, please. These next two slides include diagrams to illustrate key parts of the chronic condition measure construction. As mentioned, we identify the start of a clinician-patient relationship to treat or manage the condition by looking for a pair of services billed by the same TIN or clinician group within a certain number of days of each other. These services represent the specific condition and can be paired with diagnosis codes. The trigger event opens an attribution window, and this can be extended if we see a claim that reaffirms continuing care. If there are multiple reaffirming claims, as shown by the striped and spotted triangles here, each will have the effect of extending the total attribution window. Next slide, please. The total attribution window for a chronic measure begins with a trigger claim and concludes a set period of time after the final reaffirming claim, for example, 1 year. As a result, this window can span multiple years and vary in length for different patients. To create comparable units, we define an episode as a segment of the total attribution window that's assessed in the performance period that the episode concludes in. This diagram illustrates how a total attribution window is divided into episodes. Episode 1 is assessed during performance period 1 because that's the performance period in which the episode ends. Next slide, please. Now that we've covered the measure construction, the next few slides provide a bit more detail about each measure, starting with the heart failure measure. This measure is something that we've had on our radar for several years as an important clinical topic to cover. It is both costly and affects a large number of patients. An inpatient heart failure measure was actually identified as a strong candidate for development as early as 2017 in Wave 1 of development by the Cardiovascular Disease Management Clinical Subcommittee. This was echoed in Wave 2 by the same subcommittee and also by our TEP. The chronic condition framework offered the opportunity to assess outpatient management and treatment for heart failure as a more comprehensive way of capturing important costs rather than just focusing on inpatient care. The heart failure measure addresses heterogeneity in the patient population by risk adjusting for many pre-existing conditions such as right heart failure. Something that is common across all our cost measures is that they aim to capture all clinicians who are playing a similar role in care. So when we're developing the first set of chronic condition cost measures, our TEP emphasized the importance of capturing both primary care and specialists who are managing and treating the condition. This table shows some summary statistics about the number of episodes and clinicians being attributed under this measure when applying a 20-episode minimum. As you can see, the heart failure measure does indeed capture both general and specialist clinicians. Cardiologists have the largest number of episodes and also make up the largest share of clinicians being attributed, with over 10,000 clinicians being attributed. This last column shows the share of clinicians within given specialty that are being covered. So this is showing that around 30% of cardiologists have at least 20 heart failure episodes. One thing to note about the percentage column here is that specialties do vary a lot in size, so the share of internal medicine clinicians being covered looks low, but that's because it's a very large specialty. Next slide, please. Next, we have the Major Depressive Disorder measure. Developing measures for mental health and behavioral health is something that we've been tracking as an important gap, as well as a CMS priority area. In the public comment period for measure prioritization, we heard from stakeholders that they supported the Major Depressive Disorder measure over other potential measures like bipolar and schizoaffective disorder, as it has clear clinical practice guidelines. It also affects a large number of patients and offers opportunities for improvement, such as the integration of primary and mental health care and medication or treatment adherence. Like with heart failure, this measure aims to identify the start of a care relationship for all clinicians providing care for major depressive disorder. As such, we worked with our work group to identify a comprehensive range of services to initiate this relationship. This includes outpatient evaluation and management, or E&M codes, psychotherapy, collaborative care management, brain stimulation therapy, chronic care management codes, and others. The breadth of these codes reflect the importance of recognizing the role of different specialties, such as clinical psychologists, who contribute to the management of the condition in an integrated care team. These service codes must be paired with a depression-related diagnosis to ensure that the measure is focusing on this particular condition. Here we have a similar table to what we saw in the previous slide, which shows the top 3 most frequently attributed specialties, which are internal medicine, family practice, and psychiatrists. Next slide, please. The third measure that shares this framework is the low back pain measure. Stakeholders, including our TEP, has shared feedback over the past few years about the need to create a measure that captures care provided by physical therapists as a large specialty that didn't have any other cost measures. During the public comment period, we sought feedback on potential therapy-related cost measure concepts. Stakeholders supported low back pain since it is a very common condition affecting a large number of patients. They also noted that it has a strong opportunity to improve the value of care and has clear clinical practice guidelines. We expanded this measure concept to also bring in other clinicians who also play a role in the outpatient management of low back pain. As such, the measure uses a broad range of trigger codes to identify the start of a care relationship, including outpatient E&Ms, therapy, evaluation and services, chiropractic manipulation, osteopathic manipulation, imaging, spine injections, and others. These services must be accompanied by a low back pain diagnosis code. With such a broad measure concept, the measure uses a variety of techniques to account for patient heterogeneity. First, it stratifies episodes into subgroups based on 2 factors that affect expected spending: whether a patient has any of the 3 conditions, radiculopathy, spinal stenosis, or spondylolisthesis, and whether a patient has had a spine surgery during the episode. Second, the measure risk adjusts for other conditions and pre-existing risk factors. This includes other conditions like spondylosis, scoliosis, and other spinal deformities, depression, and osteoarthritis. Finally, the measure also excludes small sets of episodes such as for myelopathy, osteoporotic compression fracture, trauma, Cauda-Equina syndrome, and infection. The testing shows that, as intended, the measure captures a large patient cohort as well as clinicians who do not have other cost measures such as chiropractors and physical therapists. Next slide, please. I'll now walk through the construction for the psychoses and related conditions and emergency medicine measures. Next slide, please. This slide outlines the basic construction for several types of episode-based measures, including acute inpatient medical care, procedures, and emergency medicine. We'll start by going through these steps and then go through how the psychoses and related conditions measure uses this framework to hone in on the respective type of care. First, we define an episode by determining the codes that trigger or open an episode. The trigger also starts the episode window for a defined period of time when services can be included in the measure. As with the other measures, episodes can be stratified into mutually exclusive and exhaustive subgroups. Second, we attribute the episode to a group practice or individual clinician playing a role in the episode. Third, we assign costs to the episode for services that reflect the role of the attributed clinician. As with all the cost measures, we use standardized costs to remove differences in costs that are unrelated to care decisions. This is used to calculate the total observed episode cost. Fourth, we apply exclusions to remove certain episodes from measure calculation. Fifth, we calculate the expected cost for episodes by risk adjusting for factors outside of the clinician's influence, separately for each subgroup if applicable. Sixth and finally, we calculate the measure score as the ratio of the standardized total observed cost from step 3 to the risk adjusted episode cost from step 5. This ratio is averaged across all episodes attributed to a clinician. We then multiply this ratio by the national average observed cost to obtain a dollar figure. Next slide, please. As I mentioned, the measure is specified to capture the inpatient care for psychoses and related conditions using this overall framework. An episode begins with an admission to an acute care hospital or inpatient psychiatric facility, or IPF, for psychoses and related conditions as indicated by the payment variable MSDIG 885. The trigger service, shown by the large striped triangle, opens a 45-day episode window. The colored triangles represent assigned services, while the empty triangles are other services that the patient receives, but which are not included in the measure. Like all the other acute inpatient medical care measures used in MIPS, the episode is attributed to any TIN or clinician group that bills at least 30% of the E&M codes during the trigger inpatient stay. For attribution to individual clinicians or TIN NPIs, the episode is attributed to each clinician that bills at least one E&M code within the group meeting the 30% E&M threshold. This logic is designed to reflect the team-based nature of acute inpatient care. Next slide, please. The psychoses and related conditions measure was initially developed in 2018 during Wave 2 alongside 10 other episode-based measures. It was identified by the Neuropsychiatric Clinical Subcommittee as a priority because of the strong opportunity for improvement in care coordination and medication management. It's also one of the most frequent and costly MSDIGs, representing a high impact area. Since 2018, we've made some refinements to measure to address concerns around specific scenarios where inpatient clinicians have limited influence, while still preserving the measure intent of capturing this important aspect of inpatient mental health care. When we reconvened the work group in 2021, we presented a number of potential refinements with empirical analyses. The version of the measure being field tested now has the following updates. The episode window has been shortened. We removed the 3-day pre-trigger window, as inpatient clinicians may have limited influence over what happens before a patient is admitted to the hospital. This change also aligns the measure with the other acute inpatient cost measures. For the post-trigger window, it's been shortened from 90 to 45 days. Given that the average length of stay is about 14 days, this allows the measure to align with 30-day post-discharge readmissions and other quality measures that commonly use this period. We also implemented exclusions for limited and very specific scenarios where inpatient clinicians may have less ability to influence care. These are patients who transferred to state psychiatric hospitals and patients who are under involuntary commitment or court holds. Next slide, please. Besides these limited updates to the measure, the psychoses and related conditions measure still uses a range of techniques to account for patient heterogeneity. One method, given the breadth of care captured by MSDIG 885, is to stratify into clinically homogeneous subgroups. These are clinical categorizations based on hierarchical logic and comorbidities. From our testing, we can see that the greatest proportion of episodes and beneficiaries in the measure are within the schizophrenia spectrum disorders and schizoaffective disorders subgroups. Other approaches that the measure uses include exclusion and risk adjustment. In addition to the exclusions we mentioned in the previous slide, the measure excludes patients admitted for a diagnosis unrelated to psychoses and care settings other than short-term stay acute hospitals or IPFs. It also risk adjusts for individuals with a history of delusional disorders, individuals with pre-existing conditions such as delirium and encephalopathy, anemia, osteoarthritis, and substance use disorder, and for specific services such as electroconvulsive therapy, or ECT, injectable antipsychotics, neuropsychiatric testing, and nursing facility physician visits. Next slide, please. The final measure being field tested is the emergency medicine measure. This was selected because it offered the opportunity to comprehensively assess ED care, which is a large specialty that didn't have a measure focusing on this clinical role. It's also has strong potential to be impactful, with potential areas of improvement for care coordination, discharge planning, and communication. Here we illustrate how the episode construction steps capture care for emergency medicine. An episode begins when a patient presents at the emergency department and is seen by a clinician, as indicated by an ED/E&M code. The trigger service, shown by the large striped triangle, opens a 30-day episode window that captures services occurring downstream. The measure uses multiple techniques to account for the heterogeneity across patients and care pathways. The measure is stratified into ED visit types. These are shown in the next slide and represent high-volume ED conditions and other care categorized by organ system. Given that there are cost differences between patients who are admitted to hospital and who are discharged home, the measure uses a categorical risk adjuster for the MSDRG of the hospital admission. The measure also risk adjusts for observation stays and transfer from an institutional PAC setting to the ED. One difference from other episode-based measure is that this measure includes the cost of all parts A and B services during the episode window, except for clinically unrelated services specific to each ED visit type. This is to reflect the scope of the measure, which is to assess all ED care, which spans many reasons why patients attend an ED. That is, it's a broad role that encompasses many clinical reasons, which is more accurately reflected by including all services with a set of exclusions for a short episode window. Next slide, please. Episodes within each ED visit type are only compared with other episodes in that same visit type. The ED visit types are based on diagnosis information during the ED visit and arranged in a hierarchy based on highest expected resource use if there are multiple diagnoses. From our testing, we can see that the greatest proportion of episodes in this measure are categorized within the respiratory, gastrointestinal or liver conditions, and kidney and urinary ED visit types. Next slide, please. Now we'll transition to talking more about all the field testing activities and how you can provide feedback on the draft measure specifications. Next slide, please. As mentioned, the purpose of field testing is to provide stakeholders with information about the measures so that they can provide feedback on the draft specifications to help us finalize the development process. During this time, field test reports will be available for clinicians and clinician groups that include information about how they will perform under the measure. We will also post the draft methodology and codes list that contain detailed measure specs so that you can see what's included in the measures and how they're constructed. In addition, we put together supplemental documentation that provides testing results and additional information, such as summaries of the development process. We'll consider any feedback and share it with the work groups when discussing ways to further refine the measures. Next slide, please. The field test reports will be available for download on the QPP portal for clinicians and clinician groups who have been attributed at least 20 cases for at least one of the measures. This volume threshold of 20 episodes is just for the purposes of field testing. The table shows the number of clinicians and clinician groups meeting the volume threshold for each measure. A total of nearly 67,000 clinician groups and nearly 190,000 clinicians will receive at least one field test report during this period. There's a separate field test report for each measure that you have the minimum number of episodes for, so you might receive more than one measure-specific report. Each report is in the format of a zip file and includes a PDF measure-specific report, CSV file with detailed episode-level information, and a data dictionary workbook for the CSV file. For stakeholders who don't receive field test reports, there are mock reports available on the MACRA feedback page that you can look at. Links to this page and other resources are included at the end of this presentation. Next slide, please. In addition, we've posted draft measure specifications on the MACRA feedback page. This includes measure methodology, which explains the measure construction, and the codes list, which details the medical codes used to construct each element of the measure. These include triggers, subgroups, specialties, assigned services, risk adjusters, and exclusions. We also have a document that lists a set of questions for each measure. These questions are intended to provide a starting point for folks to review when thinking about specifications, but you can provide feedback on any aspect of the measures. Next slide, please. There's also supplemental documentation that you can review. These include testing results, such as descriptive statistics about measure scores, breakdowns by provider characteristics, services that are driving costs, and examinations of episode exclusions. In addition, there's a summary of the measure development process for Wave 4 and an FAQ document. Next slide, please. You can provide feedback on the draft measure specifications for the 5 episode-based cost measures from January 10th to February 25th, 2022 through the online survey listed here. When submitting feedback through the survey, you can also attach a PDF or Word document, such as if you'd prefer to submit a comment letter instead of providing responses to each survey question. You can also submit comments anonymously if you prefer. Next slide, please. Now that we've discussed the field testing process, we'll provide more detail on the information available in the field test reports. Next slide, please. The field test reports are intended to provide information about how you would have performed on the measure as currently specified. Each time we conduct field testing, we continue to update and improve our process based on stakeholder feedback. This year, we've made some updates to the structure of the field test report and the format of the data dictionary to streamline the information and make it easier for you to review. The PDF report contains a summary of your score, how it compares to other clinicians, and different breakdowns of what costs are included in your measure. The report also contains a summary of the measure specifications, now in the form of a flowchart for quick reference. An accompanying CSV file provides episode-level details for attributed clinicians and groups interested in more granular data, and a data dictionary which explains the metrics. If you meet the minimum volume of cases for a measure, you can download a zip file with all this information. The next few slides walk through the key metrics provided in the field test report. Section 1, Measure Score, provides a high-level summary of the cost measure, the clinician or clinician group's results, and a distribution of national measure scores. This table included in the field test report shows the cost of services you provide for care and how you compare with other clinicians or clinician groups. The cost measure score indicates the average risk-adjusted cost for all of a clinician or clinician group's episodes. The national average cost measure score is the average risk-adjusted cost to Medicare across all episodes nationally. And finally, the cost measure percentile indicates the percentile of your performance on the score amongst all clinicians or clinician groups nationally, where a higher percentile value indicates that your episodes are relatively more expensive than others. Next slide, please. Section 2, Breakdown of Cost Measure Performance, provides information on different ways of characterizing what types of costs are included in the measure and a comparison of your performance to other clinicians. Characterizations include Medicare setting and service category, as well as clinical theme. These are clinically related services, and it is a way of presenting clinically related services included in the measure. This section also outlines which other clinicians are most involved in the care of your patients. Next slide, please. As an example, the Medicare setting and service category table provides a breakdown of service use and cost by various characterizations, as shown highlighted in this red box. The table includes Medicare A/B services and Part D if applicable. Settings include outpatient, ancillary, hospital inpatient, ED, post-acute care, and more. These categories show how often your episodes have particular services and allows you to compare this to the national average and to others within your risk score bracket with a similar case mix and complexity. Next slide, please. To provide more context on how we create these risk brackets, a risk score is first calculated for each episode as the ratio of the expected cost for an episode to the average observed cost across all episodes for all clinicians or clinician groups. This is the expected risk for each episode. A distribution of the average risk score across all clinicians with a case min of 20 episodes is divided into deciles called risk brackets. Your average risk score across all episodes is then placed into the appropriate risk bracket, which includes clinicians who, on average, have similar episode risk scores as you. Next slide, please. Section 3, Episode Cost, provides a distribution of your episode costs, information on how to compare your score with the national average, and the share of your episodes in each of the measure subgroups, if applicable. Next slide, please. The table shown is intended to indicate on average how expensive your episodes are expected to be relative to other clinician or clinician groups episodes, as predicted through the risk adjustment model. Your distribution can be compared to a figure that illustrates a national distribution of risk-adjusted episode costs for all clinicians meeting the case min of 20 episodes. This figure was added in response to stakeholders' positive feedback on having more diagrams within the field test report. A lower percentile here indicates that your episodes are on average expected to be among the least costly episodes across all clinicians or clinician groups. Next slide, please. The additional information section of the field test report includes a flowchart with key information about the measure specifications and methodology for easy reference and a glossary of terms used within the report. We created this short summary in place of longer summaries to make the information more accessible. The section serves as a reference for you to refer to while reviewing the results of the field test report. Next slide, please. In addition to the PDF field test report, each clinician will also receive a CSV episode level file and data dictionary. The CSV provides more granular information for each episode, including identifying each beneficiary and clinician that provided care during the episode and a breakdown of costs for each episode by setting. The data dictionary provides a definition for each metric used. Next slide, please. Finally, to wrap up, we'll go through a few FAQs and some links to field testing resources. Next slide, please. These are some of the questions that we often hear about field testing and how it relates to MIPS. The first question is, who can receive a field test report? We calculate the measures using 2019 administrative claims data, so all individual clinicians and clinician groups who have at least 20 episodes for one or more of the measures will receive a field test report that you can access and download from the QPP portal. There's a report for each measure, so if you meet the volume threshold of 20 episodes for more than one measure, you'll receive more than one measure-specific report. The next question is, will these measures affect my MIPS score for 2021 or 2022? In short, no. These measures aren't in MIPS, so they're not being used for anything to do with score calculations. These measures are being field tested because this is part of the measure development process. A follow-up question is then, when will these measures be used in MIPS? There are many steps that measures have to go through before they can be used in MIPS. Since these measures are in development, we first have to finish development, which is expected to be around mid-2022. Then CMS can consider whether the measure should go to the National Quality Forum's Measure Applications Partnership, or MAP, which is a multi-stakeholder group that reviews measures and provides input to CMS about the use of measures in various programs. This is part of what we call the pre-rulemaking process. If CMS decides to move forwards with the measure after that step, the measure would go through notice and comment rulemaking, and the earliest that the measures could be used in MIPS is 2024. There'll be many opportunities for further review and to provide input through the pre-rulemaking and rulemaking stages. However, we encourage all stakeholders who are interested in the measures to share feedback with us now during field testing so that we can make any refinements to the measure now. Next slide, please. Another question that we often hear is, will the measures be used in MIPS value pathways or MVPs? They certainly could be if the measures are implemented in MIPS. Linking cost and quality is one of the considerations that our work groups keep in mind when building out the specifications for opportunities for improvement and identifying relevant quality measures that could align with a cost measure. The question of value is also something that our patient and family partners highlight when sharing their experiences with the work groups. For example, in providing examples where care could have been improved and what sorts of services were most helpful at different points in their care journey. This brings us to a question about input from person and family stakeholders. We definitely want to hear from people with lived experience of these measures. We've included questions specifically asking about various facets of care from the patient and caregiver perspective, so these can be a starting point for individuals interested in providing feedback on any or all of the measures. Of course, you can also provide feedback about other aspects of the measures as well. For more information about what input we've heard so far from our person and family partners, please feel free to review the workgroup meeting summaries on the MACRA feedback page. Finally, we've started hearing interest from stakeholders about what measures will be developed in Wave 5. It's great that people are already looking forward to future development, and this is something that we're always thinking about. We actually met with our TEP in July 2021 to talk about measure prioritization, and we've also heard a lot of feedback in previous public comment periods to give us ideas for potential future measures that would be impactful and have a strong opportunity to improve the value of care. We're expecting that Wave 5 activities would begin in 2022. If you're interested in participating in the measure development process through one of the many stakeholder engagement opportunities, we encourage you to sign up to receive updates at the link on the next slide. Next slide, please. More information about field testing, materials, and resources are all available on the MACRA feedback page. We've included the link to the QPP Access Guide, which can provide assistance with accessing field test reports. The field testing feedback survey is where you can submit your feedback either through the questions or by attaching a comment letter. Feedback must be submitted by February 25th, 2022. We also created an FAQ document with answers to frequently asked questions on policy context, field testing, and episode-based cost measures. As mentioned on the previous slide, if you'd like to receive updates on the Wave 5 measure development activities, you can sign up for our mailing list using the link on this slide. Next slide, please. Finally, if you have any questions about the information we reviewed today, please direct your questions to the QPP Service Center, which can be found at this contact information. Thank you all for joining us, and we look forward to hearing your feedback during field testing. Please reach out to the QPP Service Center if you have any questions. This concludes the recording.